Very good morning to one and all. I am Dr. Santosh. In the last classes, we had discussed regarding the thyroid gland with its anatomy physiology, and in second class we had discussed regarding the investigations. Now we shall discuss regarding the pathology of thyroid glands, and one such being the goiter. Okay, goiter is one where there is a enlargement of thyroid gland regardless of any cause. Okay, coming to definition, the normal thyroid gland is impalpable. The term goiter is used to describe generalized enlargement of thyroid gland. There are two terms that we should know, what is called the discrete nodule and what is called dominant nodules. Or discrete swelling, that is the nodule, discrete nodule, or it is sometimes called solitary nodule, is one with no palpable abnormality elsewhere, is termed as isolated or solitary nodules. Swelling. Discrete swelling with evidence of abnormality elsewhere is called dominant nodule. Okay, let us know what are the causes of thyroid disease. Okay, there are many causes. Okay, coming to there can be many causes like the inflammatory, or whether it is toxic, or whether the cause is from the autoimmune disorder, or if it is a simple uh, goiters, or it can be, the swelling can be neoplastic. Okay, coming to the inflammatory, that is, it can be acute, subacute, or chronic inflammatory disorders. Okay, and coming to toxic, it can be primary and secondary. And coming to autoimmune disorders, it can be Hashimoto's thyroiditis or Riddle's thyroiditis. Okay, and in case of simple goiters, it can be physiological, it can be colloidal goiter or nodular goiter, and in case of neoplastic, it is a benign and malignant. What is the classifications of thyroid swellings? We had already discussed in the previous class as well the classification of thyroid swellings. It can be a simple goiter where which is called euthyroid without any derangement of the thyroid hormones like T3 T4. Okay, and in case of toxic goiter, as we discussed, it can be toxic goiter, can be hyperplastic goiter, means multinodular goiter. It can be simple toxic goiter, or it can be multinodular goiters. Coming to neoplastic, as we discussed, it is a benign or malignant. In case of inflammatory, that is acute, subacute, or chronic inflammatory disorders. Coming to classification of this thyroid swellings, as we discussed, the simple goiter, that is euthyroid without elevation of this hormones, euthyroid. It can be physiological, that is in case of stress, like that is in the pubertal, or in case of stress like in the pregnancy. Okay, and second is the diffuse hyperplastic, it where you can see multinodular goiters in case of diffuse hyperplastic cause. Okay, and coming to toxic goiter, it can be diffuse, that is the Graves disease, and second, it is the multinodular. In case of first one, that is the diffuse, there is a uniform enlargement, that is the Graves disease. And in case of second is the multinodular goiters, the nodules can be, there are multiple nodules leading to toxic multinodular goiters, or toxic adenoma, as we already discussed, that is solitary adenoma, it can be only one. Okay, toxic adenoma, solitary toxic adenoma. And in case of neoplastic, it can be benign and malignant, already we discussed. Coming to classification of thyroid glands from the inflammatory origin, it can be autoimmune, chronic lymphocytic thyroiditis, Hashimoto's thyroiditis. You can see in that pathology, the Hashimoto's thyroiditis, there is a lymphocytic infiltration. What is second is the granulomatous thyroiditis, that is the de Quervain's thyroiditis. It is a granulomatous thyroiditis. And third is the fibrosing, that is Riedl's thyroiditis. Okay, this also comes under the autoimmune. Okay, and this can also be an autoimmune cause. Coming to infective, it can be acute or chronic. In case of acute, bacterial thyroiditis, or viral thyroiditis, or subacute thyroiditis. In case of chronic, it can be from the tuberculosis or syphilitic. Coming to what is simple goiter. Let us know what is the etiology of the simple goiter. The simple goiter, it can develop as a result of stimulation of thyroid gland by TSH. Okay, and it can be okay big, and this elevation of TSH, okay, it can be from two causes, that is the inappropriate secretion from the anterior pituitary, it can be a microadenoma, and and this TSH and this elevated TSH can also be in response to a chronically low levels of circulating thyroid hormones. That is the most important factor in endemic goiter is the dietary deficiency of iodine, goitrogens in food. Okay, there are different goitrogens that we'll discuss later in the subsequent classes. Okay, and in what is this defective hormone synthesis? Okay, it's a dysharmogenesis, probably accounts from many sporadic goiters. This defective hormone synthesis, it can probably account for many sporadic goiters. Okay, what is the simple goiter? This is a okay, in simple goiter what happens, there is a chronic deficiency of T4 and T3 in the body, which in turn causes compensatory elevation of TSH because of lack of necessary negative feedback. Okay, and in turn what happens is the prolonged stimulation of TSH in an attempt to bring the normal thyroid hormone levels, it leads to simple goiter. Means because of the chronic low levels of T3 and T4, this prolonged stimulation of TSH, this leads to simple goiter. Means there can be hyperplasia of the gland, of the lobules, of the thyroid lobules. Such phenomena may occur in the following settings, that is the physiological, that is in the puberty, pregnancy and lactation, and second is the iodine deficiency states. Loss of there is a less iodide contents in the food, and enzymatic deficiency in case of Penderd syndrome, which is caused by peroxidase deficiency. What is this classification of simple goiter? Simple goiters, it is classified as simple diffuse goiter, simple colloid goiter or simple nodular goiter. Pathophysiology of this goiters. The chronic absence of T4 and T3 causes elevated levels of TSH, which in turn leads to diffuse homogeneous hypertrophy and hyperplasia of follicle cells and colloid, that is secretory follicles, in an effort to produce more thyroid hormones. Okay, and this is the pathology. Because of this elevated TSH, this leads to diffuse homogeneous hypertrophy and hyperplasia of these follicular cells, which in turn produces more thyroid hormones. This is usually a reversible change. The enlarged thyroid gland causes hyperinvolution with colloid, and it is called the colloid goiter. Means I'll tell in this physiology how this colloid goiters is formed. Okay, the differential response to TSH leads to formation of nodules within the gland, and these several nodules may coalesce and lead to formation of multinodular goiter. Okay, and these nodules may undergo secondary changes, that is central necrosis, cystic degeneration, hemorrhage and calcification, and malignant changes, and this malignant changes only 3%. Okay, and this is where this colloid goiters is formed. Okay, this how this multiple nodules they coalesce because of secondary changes like the central necrosis. Okay, and how the most of these nodules, because of central necrosis, the surrounding nodules will coalesce and become colloid, and this is how the colloid goiter is formed. Most of this they coalesce and form colloid goiter in between. Okay, and other changes are calcification and malignant changes, which is only 3% malignant change. So, okay, what is the clinical presentation? How do they present? The gradual onset of painless anterior neck swelling, usually long-standing endemically in iodine deficient areas. Recent onset of pain or increase in size may indicate secondary changes. Okay, and then the enlarged gland may also affect neighboring structures and lead to wide range of symptoms and signs. Okay, this can lead to the obstruction of airways, laryngeal nerve compression, and esophageal obstruction, and neck vein obstructions, and in severe cases it can lead to superior vena cava syndrome. Means by raising the hands on clinical examination. How do you do the Pemberton sign? Is that you will raise the hands on both sides, and you can see the congestion in the neck and the face. There's a congestion that is known as a Pemberton sign. What are the investigations that we do in simple goiter? Okay, thyroid function test, obviously, whether this TSH is elevated or this T3 T4 is the levels are low. You will know by this thyroid function test. This helps to know if the thyroid gland is normal or hyper or hypofunctioning. Coming to the second next investigation is the radioactive iodine. Radioactive iodine is one where you will do when there is a features of toxicity. When there is a when the patient is showing the features of toxicity, that like the hypothyroidism. Okay, and in this investigation, a traceable radioactive iodine or technetium is injected into the bloodstream. The thyroid gland concentrates radioactive iodine. The concentrated radioactive iodine can be detected by gamma camera. The iodine 123 has a shorter half-life as compared to 131. In case of 123, it is only 30. It is only 13 hours, and in case of 131, it is 8 days, and it is therefore preferred because it has less exposure of the patient to the radiation. The thyroid scan may show hot nodules, which takes more radioactive than the rest of the gland. In secondary hyperthyroidism, however, most simple goiters have normal uptake on cold nodules, which does not take up radioactive iodine. Cold nodules are likely to be malignant. As we told, thyroid scan, if there is uptake, it is a hot nodule, and when there is no uptake, it is a cold nodule. Okay, as these hot nodules, which is described as the radioactive iodine uptake compared to rest of the gland. In secondary hypothyroidism, however, most simple goiters have normal uptake in case of secondary hypothyroidism. And in cold nodules, which does not take up radioactive iodine, that is the cold nodules. And cold nodules are likely to be malignant. And in this picture, that is the radioactive nucleotide scan, you can see that there is the cold nodule, that is the decreased uptake by the gland. And in second one, it is the homogeneous uptake of this radioactive iodine can be seen. And in case of the hot nodule, that is solitary nodule, you can see a small nodule, that is which shows radioactive scan, which shows radioactive uptake. Okay, what are the other investigations? Anti-thyroid receptor antibodies. This type of investigation is done in patients suspected to have stimulatory autoantibodies, as in case of Graves' disease. Okay, and that is the primary hyperthyroidism. Radiological investigations. As we already discussed in the last class, how this X-rays will helps in differentiating the retrosternal goiters. Okay, and this is the normal anteroposterior and lateral chest X-ray showing demonstrate retrosternal extension of the goiter. Okay, and here it also shows thoracic inlet X-rays demonstrating compression and deviation of trachea. If this can be very useful for the anesthetist to decide whether to be surgery is contemplated. That is, if surgery is contemplated, difficult intubation. Other than this investigation, what is this? This is the ultrasound neck. Ultrasound neck is a homogeneous and slightly hypoechoic. In the thyroid is a homogeneous and slightly hypoechoic. You can see on either sides the left and right thyroid. In between is the trachea, and on laterally on either sides is the carotid vessels. You can see the normal thyroid gland is 2 cm or less in both transverse dimension and depth, and is 4.5 to 5 cm in length, 0.5 mm in isthmus. A diffuse endoid thyroid gland with an isthmus width of 1.5 cm in this ultrasound scan. Other than this, the CT may be indicated if more details are needed for surgery or there is suspicion of malignancy transformation. Other than this, FNAC is the one of the most important investigation to be done. It is done to rule out the malignancy of the thyroid. Okay, and here what it says is that it can be it can be benign, malignant, suspicious, malignant, inconclusive, or inadequate, aspirate. If there is a follicular pattern is seen, lobectomy is done to exclude follicular carcinoma. In case of follicular pattern is seen, lobectomy is done to exclude follicular carcinoma because it can only be differentiated by demonstrating capsular invasion. And this you should know. This you should always know that FNAC cannot differentiate between the follicular neoplasm, okay, and follicular carcinoma, follicular adenoma with follicular carcinoma. Okay, so means that you can't differentiate the follicular capsular invasion. What is the treatment and prevention of simple goiters? Dietary, that is iodine supplementation in iodine deficient areas. Food iodine fortification is one of the best preventive measures of goiters. Medical, that is thyroxine supplementation in patients with diffuse hyperplastic goiter for several months. That the daily intake is the 0.1 to 0.2 milligram per day you should be given. And what are the surgical indications in patients with obstructive? So what are the indications in patients with obstructive symptoms and when malignancy is suspected, and when malignancy is suspected clinically or after FNAC, hyper, and when there is hyperfunctioning nodules in case of like toxic adenomas. Okay, and for cosmetic reasons. Okay, and for cosmetic reasons, and these are the indications for surgery. And what type of surgeries you will do? So like total thyroidectomy, subtotal thyroidectomy, and subtotal thyroidectomy or near total thyroidectomy, where you leave a small chunk of tissues on either side. That is the near total thyroidectomy. And there is another surgery called the Dunhill procedure, where you will leave only on one side a chunk of tissue, that is a 4 gram of tissue. Okay, and okay, and here ends the topic. Okay, thank you.